Picture a 25-year-old rugby player arriving down in A&E on a Saturday afternoon.
Right. We see it all the time.
Exactly. He's clutching his arm to his chest, his shoulder is dropped, and there is a glaring, unmistakable step-off deformity right at the top of the shoulder.
Adrenaline wearing off, I imagine.
Oh, completely. The adrenaline is gone, the pain is really setting in, but his first question isn't actually about analgesia. He wants to know exactly when he can get back on the pitch.
Of course he does.
And as the clinician looking at that shoulder, you know that if you make the wrong call today, well, his career could genuinely be over.
It's a massive decision.
It really is. So today we are undertaking a deep dive into the exact pathology standing between that player and the pitch, the acromioclavicular or AC joint injury. Welcome to Deep Dive Ortho.
Thank you.
We are moving far beyond the basic historical classifications today, getting into the intense biomechanical nuances of modern reconstruction. We really want to cut through the noise to understand exactly when surgery genuinely adds value and when it simply adds catastrophic risk.
Which it certainly can.
Absolutely. And to guide us through this, I am absolutely thrilled to introduce Professor Mo Imam to you, the listener. As sports surgeons, trauma surgeons, orthopedic trainees, and physiotherapists, you know this joint is notoriously unforgiving. Professor, it is an absolute privilege to have your clinical authority on the deep dive today to help us unpack all of this.
Well, thank you. It is a real privilege to be joining you. That clinical scenario you just described, it's one that plays out in A&E departments and fractional clinics across the country every single weekend.
Yeah, without fail.
Exactly. It's the classic mechanism, isn't it? A high-energy, direct blow to the point of the shoulder, usually with the arm adducted.
Right.
And the management of these injuries has evolved drastically over the years, yet it still remains one of the most fiercely debated topics in orthopedic trauma, primarily because the biomechanics are just so incredibly unforgiving.
They really are. I mean, I often look at the AC joint as the suspension bridge of the shoulder.
That's a great analogy.
Thanks. You have the clavicle acting as the rigid tower, right? And the coracoclavicular ligaments acting as those vital suspension cables holding up the scapula and the arm.
Spot on.
It is incredibly efficient for overhead function, but once those cables snap, it seems notoriously difficult to perfectly repair that bridge back to its original tension.
It is, because the AC joint is certainly not just a static hinge. I mean, it is a highly dynamic articulation. It dictates the kinematics of the entire shoulder girdle.
So when it fails,
When those suspension cables fail, the entire biomechanical chain is just disrupted. The scapula loses its anchor. So, to truly understand how to fix the bridge, we first have to understand the specific mechanics of how it falls apart.
right, and the foundation of that understanding still rests heavily on how we classify the structural failure, doesn't it?
It does, yes.
Okay, so every orthopedic trainee has the 1984 Rockwood classification drilled into their head on day one.
They do, yes.
But let's be honest, it's a 40-year-old system. So before we tear into its modern relevance, could you just walk me through the physical mechanics of the first few types?
Absolutely.
What is actually snapping in the shoulder to take us from, a minor ache to a full-blown structural failure?
Well, the Rockwood classification fundamentally categorizes the progressive, sequential failure of the stabilizing structures. We really have to consider two primary sets of ligaments here.
Okay.
First, you have the acromioclavicular, or AC ligaments. These form the capsule, and they primarily resist horizontal translation, so front-to-back movement.
Right, the horizontal stabilizers.
Exactly. And second, the coracoclavicular, or CC ligaments. That's the conoid and the trapezoid. These are the massive vertical suspension cables resisting superior translation.
So in a type I injury, what's happening?
In a type I, the force is relatively low. The AC ligaments suffer a sprain, perhaps some micro-tearing, but structurally the capsule remains intact.
So the cables are fine?
Yes. The CC ligaments are untouched, and the joint is completely undisplaced. Clinically, the patient just has localized tenderness over the joint, but there's no visible step-off.
Okay, that makes sense. But then as the kinetic energy increases...
Right, then we move to a type 2. Here, the AC ligaments are entirely ruptured, the capsule is just blown open, and that leads to widening of the joint space in the horizontal plane.
Oh, wow. But what about the vertical cables?
The vital vertical cables, the CC ligaments, they are only sprained, they aren't torn yet, and the thick deltotrapezial fascia lying over the top remains intact.
Okay.
So radiographically, you might see a slight elevation of the clavicle, but it's generally less than 25% displaced. relative to the Ackermann.
So types I and II are essentially structural failures in the horizontal plane, but the vertical suspension cables are still doing their job holding the arm up against gravity?
Precisely. The vertical integrity holds. But type 3, that is the watershed moment where true anatomical disruption begins.
This is where the bridge collapses.
Exactly. The kinetic energy shears completely through both the AC capsule and the robust CC ligaments. The suspension bridge has officially failed.
So the clavicle pops up?
Well, we say the clavicle is elevated, but more accurately in biomechanical terms, the heavy arm and the scapula are depressed by gravity.
Ah, right. It's the arm dropping, not just the collarbone rising.
Exactly. And this results in a displacement of 25 to 100% of the clavicular width. Yet, crucially, the delta trapezial fascia often remains partially intact.
Which provides some residual stability.
It provides a minor, highly unpredictable degree of residual stability, yes.
And from there, we move into the truly severe high-energy variants, right? Types 3, V, and 6, where the anatomy is just completely devastated.
Completely devastated.
Yeah.
Type 1 is a really fascinating anatomical variant, and it catches a lot of people out.
Why is that?
Because the clavicle is forcefully displaced posteriorly. It's driven straight into or even through the trapezius muscle belly.
Oh, wow. Through the muscle.
Yes. So on a standard AP radiographs, a type 4 can actually masquerade as a type 2 or a type 3 because the displacement is purely horizontal, straight backwards. It doesn't look as bad vertically.
It's a massive trap for a junior doctor in A&E.
It's a huge trap. Then you have type V, which is a catastrophic soft tissue failure. The AC ligaments, the CC ligaments, and the heavily investing delta trapezial fascia are all completely stripped away from the bone.
Just entirely degloved, essentially.
Essentially, yes.
Okay.
The clavicle is displaced superiorly by 100 to 300%. The skin is severely tented, visibly blanching under the pressure of the bone, and the patient is in exquisite agony.
I can imagine. And type 6?
Type 6 is exceedingly rare. It's usually the result of extreme trauma, like a high-speed motor vehicle collision or severe crush injury. The clavicle is actually dislocated inferiorly.
Inferiorly?
Yes, driven down under the Ackermann or conjunctive process, trapping the biceps or the conjoined tendon. It often presents with severe neurovascular compromise.
That progression really highlights just how violent these injuries are. But getting that classification right relies entirely on the quality of our imaging, doesn't it?
It absolutely does.
And there is a clinical pearl here that often gets completely missed in busy trauma units. Static, supine, or even standard upright x-rays can entirely hide the true extent of the damage.
They can hide it beautifully.
So talk me through the biomechanics of muscle guarding. Why are weight-bearing radiographs or stress views absolutely non-negotiable when we suspect an AC joint injury?
Well, when a patient is in acute pain, their natural physiological reflex is to guard the injured limb. They subconsciously recruit their large neck and shoulder muscles, the trapezius and levator scapulae, to pull the heavy arm up.
Right, taking the weight off.
Exactly, taking the tension off of the torn tissues. So by elevating the scapula, they effectively reduce the AC joint deformity artificially.
So they fix the step off themselves temporarily.
Temporarily, yes. If you shoot a standard radiograph at that exact moment, a complete type 3 rupture where all the ligaments are shredded, well, it might look perfectly aligned. It'll be misdiagnosed as a type I or 2.
Because the patient's own muscle spasm is temporarily acting as the broken suspension cables.
That is exactly it. The muscular compensation masks the ligamentous incompetence. So, to unmask the true pathology, we must deliberately fatigue or bypass that muscular compensation.
And how do we do that in a practical sense?
We ask the patient to stand and hold a weight, typically around 5 to 10 kilograms in each hand, and we tell them to let their arms hang entirely dead and relaxed.
Which must be quite uncomfortable for them.
It is, but it's essential. This load physically forces the scapula to drop downwards. If the CC ligaments are competent, the clavicle will follow the scapula downward.
Right.
But if the CC ligaments are ruptured, the scapula drops under the weight, while the clavicle remains high, pulled superiorly by the sternocleidomastoid muscle attaching at the medial end.
And suddenly the step-off deformity just reveals itself.
It becomes glaringly obvious. It is fundamental biomechanics revealed through dynamic imaging. And we also strongly advocate for the Zanka view alongside this.
Right. angling the X-ray beam 10 to 15 degrees cephalid.
Yes.
I always try to visualize the physics of that angle. By tilting the beam up slightly, you're essentially shooting straight through the joint space, aren't you?
You are.
Because it removes the superimposition of that thick scapular spine that usually clouds a standard AP view.
Exactly. It throws the scapular spine out of the visual field entirely. It gives you this crystal clear, unobstructed silhouette of the joint articulation.
So we really have to push the anatomy to its limit to see where the failure lies. But let's look critically at the Rockwood system itself. We are heavily relying on a classification from 1984 that measures percentages of vertical displacement on two-dimensional static X-rays.
Yes, and that is a major limitation.
Because a shoulder operates in 3 dimensions, surely static vertical displacement doesn't always correlate with the dynamic dysfunction a patient experiences when they actually try to use their arm.
It doesn't. Rockwood was a really necessary foundation, but it inherently ignores the transverse plane.
Yeah.
It predominantly focuses on vertical instability.
Right.
And this is exactly where the ISOCOS consensus, that's the International Society of Arthroscopy, Knee Surgery, and Orthopedic Sports Medicine, they stepped in to address a massive gray zone within the classification.
Specifically concerning the horizontal instability, right?
Precisely. Because a shoulder might look vertically acceptable, but if it is shifting anteriorly and posteriorly by 2 centimeters every time a patient reaches across their body, well, that is a profoundly dysfunctional, painful shoulder.
So they subdivided that notorious type 3 category, the one that causes endless arguments in multidisciplinary team meetings.
Yes, the classic MDT debate. The ISOCOS modification broke type 3 into type IRI and type IIB.
Okay, let's break those down.
Type IRI is a vertically displaced but horizontally stable injury. The ligaments are turned, the clavicle sits high, but when the clinician performs a dynamic cross-body adduction test in the clinic, the clavicle does not override the acromion.
So the scapula moves synchronously with the chest wall.
Exactly. The intact fascial sleeves are doing enough to prevent anterior-posterior shear. And these patients generally do exceedingly well without any surgical intervention.
But type IB is the problematic one.
Type IA is highly problematic. It is vertically displaced and horizontally unstable. The dynamic stabilizers have utterly failed.
So when they move,
When the patient crosses their arm over their chest, you can physically see and feel the distal clavicle translating backwards, grinding against the acromite.
that sounds horrendous.
It is. This horizontal shear is a massive generator of chronic pain, mechanical catching, and secondary scapular dyskinesia. The ISOCOS modification fundamentally mandates that we assess the front-to-back shear, not just the up and down displacement.
That distinction is just vital because deciding what to do with a type 3 injury is the absolute pinnacle of orthopedic controversy. It is the classic dilemma to cut or not to cut.
It really is. For types I and II, the global consensus is conservative management. Full stop. And for the severe biomechanical disruptions of types Thor, V, and 6, surgical reconstruction is absolutely mandatory.
Because the anatomy is just too far gone.
Exactly. But type 3 sits squarely in the middle. Complete disruption of the vital ligaments, moderate to severe displacement, but with highly variable functional demand from the patient.
Hold on, let's look at the data here, specifically the Canadian Shoulder and Elbow Society trials, because they ran a massive multi-center randomized clinical trial on this.
They did, a landmark study.
And you're telling me a patient's clavicle is entirely detached, poking up into their skin, the ligaments are shredded, and the data suggests we just leave it alone. How does the shoulder not just collapse during a rugby tackle or, heavy lifting?
I know, it is entirely counterintuitive to the traditional surgical mindset, which is precisely why those trials were so paradigm-shifting.
What do they actually do?
The Canadian researchers took a robust cohort of acute type 3 injuries and randomized them into 2 rigid pathways: surgical reconstruction versus strict conservative management with structured phased physiotherapy. And the methodology was meticulous. They tracked these patients using validated outcome measures, like the DASH score disabilities of the arm, shoulder, and hand, and constant scores. They also tracked hard, practical metrics like time to return to work and return to sport.
And what did they find?
The definitive conclusion was stark. At the 2-year mark, and even out to 5 years, there was no statistically significant difference in functional outcomes or pain scores between the operative and non-operative groups.
That is staggering. So the body just finds a way to compensate for the missing ligaments.
The human body is remarkably adaptable. Through targeted physiotherapy, patients recruit their parascapular musculature, the trapezius, serratus anterior, and rhomboids to dynamically stabilize the scapula.
Wow.
They essentially build a muscular suspension bridge to replace the torn ligamentous one. Furthermore, the conservative group returned to work and sport significantly faster.
Well, because they didn't have to recover from a massive operation.
Exactly. And they entirely avoided the formidable risk profile of surgery infection, hardware failure, vascular injury, and aesthetic risks. The data heavily supports the conclusion that the vast majority of type 3 injuries function beautifully with conservative management.
Okay, but if the macro data says most do well conservatively, the million-dollar question for the surgeon listening right now who is staring at a waiting room full of patients is, how do we proactively identify the specific subset of patients who won't do well?
That is the art of patient selection.
Because a professional rugby player or a scaffolder might not tolerate a surgically neglected type 3 the same way I would sitting at a desk.
You're absolutely right. Identifying the surgical candidate in a type 3 scenario requires a forensic assessment of their functional demands. We had to treat individuals, not statistical averages.
So what's the primary clinical decision point?
It's occupation and athletic demand. A heavy manual laborer working overhead or an elite overhead athlete like a tennis player or a volleyball attacker places immense repetitive shear forces across that joint. Their biomechanical tolerance for a floating distal clavicle is exceptionally low. The muscular compensation we just discussed, well, it will quickly fatigue under those extreme loads, leading to pain and dysfunction.
So for them, surgery is better.
For these high-demand patients, early surgical stabilization is highly advantageous.
Okay, and what's the second crucial factor?
The second factor is the presence of intractable scapular dyskinesia. If the loss of the suspension cables causes the scapula to protract and wing severely, it alters the glenohumeral mechanics.
Oh, right.
And that patient is going to develop secondary rotator cuff pathology and subacromial impingement. If a targeted 6-week physiotherapy program cannot restore synchronous scapular rhythm, surgical intervention is required. We have to restore the anatomical anchor point for the scapula.
So you are essentially looking at the downstream mechanical effects. The AC joint might be the primary injury site, but if it is actively ruining the mechanics of the entire shoulder girdle, you have to step in.
Exactly. And the final factor is chronicity of pain. If a type 3 patient is trialed on conservative management, but remains significantly symptomatic with horizontal instability, that isocose type IUB presentation we mentioned, at the 3 to 4 month mark, they cross over into the surgical cohort.
Right. And I know half the surgeons listening right now are sweating about the timing. Because patient selection is an art, but timing seems to be governed by strict biological laws.
It absolutely is.
Let us explore this timing conundrum. What exactly is the difference in tissue healing potential between an acute AC joint injury and a chronic one? What is the cellular degradation actually happening to those CC ligaments as the weeks tick by?
It is an unforgiving race against biology. In the acute phase, which we typically define as within the first 2 to 3 weeks post-injury, the torn ends of the conoid and trapezoid ligaments are highly viable.
You're still alive, essentially.
Very much so. They
Yeah.
possess a robust blood supply, the fibroblast activity is peaking, the collagen matrix is reactive, and the surrounding biological milieu is just primed for healing.
So if we go in then,
If we surgically reduce the clavicle and hold it in its precise anatomical position during this acute window, those native ligaments have an excellent capacity to scar back together and heal in a biomechanically sound fashion. We just act as a temporary internal splint while nature executes the repair.
but what happens if we wait too long?
However, once we cross that 3 to 4 week threshold, the biology alters permanently. The torn ligament ends retract significantly. They lose their blood supply, undergo necrosis, and transform into disorganized, non-functional scar tissue.
So they just die off.
The biological degradation is irreversible. The native CC ligaments lose their structural integrity, and their healing potential drops to absolute zero.
It's like tailoring a suit, isn't it? Acute repair is like stitching a clean cut in the fabric. You approximate the healthy edges, and it holds beautifully.
That's a great way to think about it.
But attempting a delayed reconstruction is like trying to tailor a suit with frayed, shrinking, rotting fabric. You cannot just pull those old necrotic pieces together and expect them to hold tension under a heavy load.
You absolutely cannot rely on the native tissue in a chronic setting. Simple reduction and fixation will inevitably fail because the body cannot bridge the gap with competent tissue.
So what do you do?
You are forced to abandon acute repair techniques. You have to perform a highly complex biological reconstruction using autograft or allograft tissues, such as a semitendinosus hamstring tendon, to recreate the ligaments entirely from scratch.
And the clinical outcomes reflect that biological reality, don't they?
The disparity is profound. Chronic reconstructions yield significantly poorer outcomes compared to acute fixation across almost every metric.
Really? Across the board?
Yes, chronic procedures have higher complication rates, a greater incidence of persistent pain, massive rates of hardware failure or tunnel widening, and lower patient satisfaction scores. The surgical footprint is larger, the bone tunnels required are larger, the operative time is doubled, and the rehabilitation is substantially more prolonged.
This just underscores the absolute critical nature of early referral. For the physiotherapists and A&E clinicians listening right now, if you see a high-demand patient with a highly displaced type 3 or a type 4V, sitting on that referral to see how it settles is doing them a massive disservice.
It really is. The ideal window for surgical intervention is within the first 2 to 3 weeks. If frontline clinicians identify a severe AC joint injury, urgent referral to a shoulder specialist is paramount.
Because delay changes everything.
Exactly. Delaying a surgical consultation for 6 weeks transforms a relatively straightforward, highly successful acute repair into a highly complex, biologically demanding chronic reconstruction with a worse prognosis. We simply must respect the biological clock.
Well, I want to dive deep into the surgical playbook now because the hardware and techniques have evolved drastically. But to appreciate why we use high-tensile sutures and biological grafts today, we have to look at the spectacular failures of what we used to do.
The history of AC joint surgery.
Yes, because for decades, the undisputed gold standard was the modified Weaver-Dunn procedure. Walk me through the mechanics of this operation. How were surgeons trying to fix this back in the day?
Well, the Weaver-Dunn procedure, originally described in the early 1970s, was a masterclass in anatomical resourcefulness for its era.
Okay.
The concept was straightforward. If the massive coracocclavicular ligaments are destroyed and necrotic, we need to replace them with a local, expendable structure.
Makes sense on paper.
It did. The surgeon would first excise the distal centimeter of the clavicle to prevent arthritic impingement against the acromion. Then, they would identify the coracoacromial ligament, the CA ligament, which natively spans from the coracoid process over to the acromion, forming the roof over the rotator cuff.
Right.
They would detach the acromial end of this ligament, preserve its attachment to the coracoid, and forcefully transfer it. They'd swing it medially to attach it into the hollowed-out medullary canal of the resected distal clavicle.
Wow.
The idea was to turn a static ligament that protected the cuff into a dynamic suspension cable for the clavicle.
I mean, using the body's own spare parts sounds incredibly elegant, but clearly not all ligaments are created equal. Why did this procedure fail so consistently over the long term? What was actually happening biomechanically when these patients went back to lifting or playing sport?
The failure lies entirely in the vectors of tension and the inherent mechanical properties of the tissue.
Revectors.
Yes. The native conoid and trapezoid ligaments are immensely thick, vertically oriented, and incredibly strong. Their collagen alignment is perfectly designed to resist severe superior translation of the clavicle.
Okay, and the CA ligament.
The CA ligament, however, is much thinner. More importantly, its natural orientation is primarily horizontal and anterior.
Oh, I see.
When you surgically transfer it to the distal clavicle, you are suddenly asking a relatively weak, horizontally oriented ligament to perform the heavy lifting of two massive, vertically oriented ligaments. It is a severe biomechanical mismatch.
It's just not built for that kind of load.
Exactly. If you look at the stress-strain curves of these tissues in laboratory studies, the CA ligament possesses only a fraction of the tensile strength of the native CC complex. Under the dynamic, repetitive loads of daily life, the transferred tissue slowly stretches out, elongates, and eventually just fails to hold the scapula up.
So it was doomed by physics from the start. So why did it take decades for the orthopedic community to abandon it? What was the tipping point in the literature?
The tipping point arrived with the publication of robust, long-term systematic reviews, most notably the landmark papers by Beitzel and colleagues.
Right.
They aggregated the long-term follow-up data and exposed the harsh reality of the Weaver-Dunn. The short-term outcomes looked acceptable, but the long-term clinical outcomes were deteriorating rapidly.
What were surgeons actually seeing in clinic?
They were seeing unacceptably high failure rates, massive loss of radiological reduction where the clavicle just slowly migrated back up as the ligament stretched, and persistent debilitating weakness in the shoulder girdle.
That's awful.
The literature demonstrated unequivocally that the CA ligament transfer was biomechanically inadequate. The procedure simply could not withstand the test of time, and the global orthopedic community rightfully pivoted.
And that pivot ushered in the modern surgical arsenal, which is where I want to spend a massive amount of time because this is the current high-stakes battlefield of AC joint surgery. We moved into the era of advanced hardware and precise anatomical reconstructions.
It did.
Let's start with the rigid fixation camp, the hook plate. How exactly does this piece of metal leverage the anatomy to achieve reduction?
The hook plate is a highly effective, rigidly engineered solution, deployed almost exclusively in acute injuries where the native ligaments just need a temporary rigid environment to heal.
Okay, how does it work?
The mechanics are elegantly brute force. It is a robust titanium osteosynthesis plate that sits directly on the superior surface of the distal clavicle, secured with cortical screws. However, its defining engineering feature is a smooth, contoured metallic hook projecting from the lateral end.
And where does that hook go?
During the operation, the surgeon physically reduces the clavicle downwards and slides this hook underneath the acromion.
Oh, underneath it.
Yes, the plate essentially uses the underside of the acromion as a mechanical fulcrum. It levers against the acromion to physically hold the clavicle down in its perfectly reduced anatomical position. It completely neutralizes the deforming forces of the trapezius and sternocleidomastoid.
So it locks it in place.
It provides the absolute rigid stability those native CC ligaments require to bridge the gap and heal.
The mechanics make sense, but there is a glaring clinical pearl, a massive warning attached to the hook plate. The most common complication isn't the plate failing to hold the bone, is it? It is the failure of the surgeon or the hospital system to plan its removal.
That is the tragedy of the hook plate, yes.
Why is leaving a hook plate in situ past the 3 to 4 month mark so catastrophic for the patient?
Because the AC joint is not a fused static syndesmosis. It is a highly dynamic articulation that must rotate, elevate, and translate during normal arm movement.
Right, we talked about that.
By placing a rigid titanium hook under the acromion, you have effectively pinned and locked a dynamic joint.
Which sounds disastrous if they try to move.
It is.
Yeah.
If that metallic hook is left in place while the patient returns to normal, aggressive range of motion, the repetitive friction of metal grinding against bone causes immense irreversible damage.
Oh, wow.
It leads to severe acromial osteolysis. The bone of the acromion literally dissolves and resorbs under the relentless pressure of the titanium hook. It narrows the subacromial space, chewing through the underlying rotator cuff tendons, causing massive iatrogenic impingement and cuff tears.
That's devastating.
In severe cases of neglected removal, we see catastrophic hardware failure, where the plate fractures from metal fatigue or the hook burrows entirely through the acromion, fracturing completely.
It's exactly like internal scaffolding used to build a stone archway. The scaffolding is absolutely essential for the initial build, holding the heavy stones in place while the mortar sets.
That's a brilliant comparison.
But if you leave the wooden scaffolding inside the archway and start running heavy traffic through it, well, the structure is going to tear itself apart. The scaffolding has to be evicted the second the mortar is dry.
And the 3-month eviction notice for a hook plate is strict and non-negotiable. It requires a mandatory second surgery under general anesthetic purely to remove the metalwork.
Nobody wants a second surgery.
Exactly. This inherent necessity for a second operation, along with the risks of subchromial erosion, is exactly what drove the evolution toward the next generation of implants. Flexible, non-rigid fixation.
Which brings us to the tightrope and modern suture button techniques.
Yes, exactly.
Right. So we finally figured out that bolting a dynamic joint to a rigid metal plate was a terrible idea. We had to find something that acted like a high-tensile bungee cord rather than a steel beam.
Precisely.
Walk me through the biomechanics of these cortical button techniques and, crucially, where the technical surgical risks lie in theater.
The conceptual shift here was moving from rigid metal plates to high-tensile, ultra-high molecular weight polyethylene suture tape. The technique is conceptually simple, but technically highly demanding.
What's the process?
It involves drilling a precise bone tunnel vertically down through the clavicle, and then continuing that drill path directly through the base of the coracoid process, located deep below it.
Okay, so you're making a continuous tunnel.
Yes. We then pass a heavy braided suture tape construct through these aligned bone tunnels. At the bottom, exiting underneath the coracoid, the suture is secured with a small, flat metallic or composite cortical button that flips horizontally to anchor against the bone.
Like a toggle.
Exactly like a toggle. At the top, Resting on the clavicle, another button is threaded onto the sutures. The surgeon pulls the sutures, tensioning the construct and reducing the clavicle, and then ties it down over the top button. This suture loop essentially mimics the biological vector of the native CC ligaments. It holds the clavicle down tightly against superior translation, but because it is flexible suture tape and not a rigid plate, it allows for the natural, necessary rotation and micromotion of the clavicle during shoulder elevation.
It is far more physiological. But as a surgeon, you are drilling blind holes deep into critical anatomy. What is the nightmare scenario here in theater?
The risks are profound, if not executed flawlessly. The coracoid process is a relatively small, strangely shaped, curved protrusion of bone. Drilling a 4 mm tunnel through its exact anatomical center is technically extremely demanding, even with modern targeting guides.
And if you miss the center?
If the drill angle is slightly off, or if the tunnel is drilled eccentrically, meaning too close to the medial or lateral cortex of the coracoid, it creates a massive stress riser in the bone.
Which leads to?
The nightmare complication with suture buttons is a subsequent coracoid fracture. If the patient falls during rehab, or if the suture tape applies too much pressure against a thin cortical wall, the entire coracoid can shatter.
That sounds like an absolute disaster.
It results in complete catastrophic failure of the fixation and requires incredibly complex revision surgery. Furthermore, we frequently observe button pull-through.
What is that?
It's where the high tension on the top button causes it to slowly erode and sink through the soft, cancellous bone of the clavicle over several months. That leads to a gradual loss of reduction and a return of the deformity.
Which really highlights the harsh reality that no implant is perfect. We have rigid plates that eat the acromion and flexible buttons that risk fracturing the coracoid.
Exactly. Everything is a compromise.
But what about the chronic setting we discussed earlier? When the biology is completely dead, we cannot just rely on sutures to hold the joint together forever, can we? We have to biologically rebuild the ligaments.
We do.
Talk us through anatomic coracoclavicular reconstruction, or ACCR, because this sounds like an incredibly extensive procedure.
ACCR is the undisputed gold standard for chronic instability. This is a highly complex biological reconstruction. We completely abandon the idea of simply pulling bones together with hardware. We are meticulously grafting new living tissue.
Where do we get the tissue from?
We typically harvest a robust autograft, such as the semitendinosus tendon from the patient's own hamstring, or we utilize a sterilized, high-quality allograft.
Okay.
The goal is to anatomically recreate the exact V-shaped footprint of both the conoid and the trapezoid ligaments. We loop this thick tendon graft securely under the base of the coracoid and pass the two limbs through carefully placed bone tunnels in the clavicle, specifically matching the native anatomical insertion sites.
But a tendon graft doesn't just stick instantly, does it?
No, a soft tissue graft takes months to fully integrate and vascularize within those bone tunnels. To protect the healing graft from elongating during the first critical months, we routinely augment this biological reconstruction with a synthetic suture button device.
A belt and braces approach.
Exactly. The high-tensile suture tape takes all the mechanical load initially. It acts as an internal seat belt, protecting the biological graft from shear forces while it slowly heals and incorporates into the bone.
Looking at the literature, particularly the systemic reviews you mentioned earlier, how does ACCR compare to just using isolated suture buttons in a chronic setting? Where is the global consensus, and what is the modern controversy regarding these tendon grafts?
Well, the consensus is incredibly clear on biomechanical superiority. ACCR provides vastly superior multidirectional stability in the chronic setting compared to any non-biological fixation.
Because it's actual living tissue.
Yes. The tendon graft is thick and strong, and by recreating both the conoid and trapezoid bundles, it controls both vertical displacement and that problematic horizontal instability excellently.
So what's the controversy then?
The controversy lies in the biology of graft integration and tunnel management. When you drill large tunnels in the clavicle and pass a tendon through, you initiate a massive, complex biological healing response. We frequently observe significant tunnel widening on follow-up radiographs. As the tendon attempts to heal to the bone via Sharpie's fibers, the surrounding bone often resorts slightly due to micromotion and the ingress of synovial fluid.
Is that a problem?
While often asymptomatic, massive tunnel widening weakens the clavicle and can lead to late clavicular fractures.
Oh, I see.
So there is intense, ongoing debate over how to secure the graft within the tunnel to minimize this micromotion. Do we use inert interference screws to tightly lock the graft against the bone wall, or do we simply sew the limbs of the graft back onto themselves over the top of the clavicle?
That's a tricky balance.
It is. Furthermore, the debate between autograft using the patient's own tissue, which integrates faster but causes donor site morbidity in the leg, versus allograft, which has slightly slower integration rates but avoids harvesting native tissue, is an active discussion in every complex reconstructive clinic.
It is a phenomenal, delicate balance of rigid biomechanics and unpredictable biology. But regardless of whether you use a hook plate, a tightrope, or perform a complex ACCR, a flawless 2-hour operation in theater can be completely undone in 5 minutes in the physiotherapy clinic if the patient is non-compliant.
Absolutely, it happens all the time.
Let us explore the crucial final phase of patient care, rehabilitation and the road back to contact sports. Because a surgeon's meticulous work is only as durable as the rehab that follows. Professor, break down the specific phased rehab protocols required post-AC joint reconstruction.
Rehabilitation is unequivocally the unsung hero of AC joint surgery. We must respect the biological healing timeline of the tissues, which absolutely cannot be rushed.
So what happens in phase 1?
Phase 1, spanning the first 4 to 6 weeks postoperatively, is a period of absolute mechanical protection. The patient is strictly immobilized in a broad arm sling.
No active movement at all.
None. The biological graft, or the healing native ligaments, are at their absolute weakest point during this time, as the body undergoes the inflammatory and early proliferative phases of healing. We allow gentle passive range of motion only, usually strictly limited to 90 degrees of forward elevation, purely to prevent adhesive capsulitis, a frozen shoulder.
Got it.
Active elevation is strictly forbidden. Firing the large deltoid and trapezius muscles exerts massive superior shear force directly across our delicate surgical repair, risking immediate failure.
So the suspension bridge is entirely closed to heavy traffic while the concrete cures.
That is the exact biomechanical reality.
Okay, so moving into phase 2.
Moving into phase 2, from week 6 to 12, we cautiously transition from passive motion to active assisted, and eventually to purely active range of motion. We begin focusing heavily on periscapular stabilization exercises.
Because the scapula relies on the AC joint to move.
Exactly. Remember, the scapula relies entirely on the AC joint to pivot and rotate. We must meticulously retrain the lower trapezius, the serratus anterior, and the rhomboids to move the scapula synchronously with the humerus. We also begin gentle isometric strengthening of the rotator cuff.
And phase 3.
Phase 3, from 3 months onwards, introduces progressive, heavy resistance training. We rebuild the entire functional kinetic chain, moving from predictable, closed kinetic chain exercises to highly dynamic, open-chain, sport-specific plyometric movements.
Which brings us to the ultimate high-stakes metric, clearing the athlete for contact sports. Returning to our 25-year-old rugby player from the introduction, what specific objective metrics do you absolutely require before you let him take a heavy tackle?
It is never, ever based simply on a calendar date. It requires objective, rigorous, criteria-based progression.
What's the first criterion?
First, we require pristine radiological evidence of healing, absolutely no loss of surgical reduction, and no catastrophic tunnel widening or hardware migration on stress x-rays.
Okay.
Second, we demand a complete dynamic resolution of any scapular dyskinesia. If the shoulder blade is still winging or stuttering during elevation, the mechanics are compromised, the energy transfer is inefficient, and the joint remains highly vulnerable to re-injury.
And the final test?
Third, and most importantly, we look at objective strength symmetry. We utilize isokinetic dynamometer testing to ensure that the operated shoulder girdle has achieved at least 90% of the strength, endurance, and power of the uninjured contralateral side.
That's a high bar.
It has to be. Only when they pass these rigorous biomechanical and functional tests are they cleared for the violent, unpredictable, multi-directional forces of contact sports. Usually this biological and functional maturity is reached around the 6-month mark.
I have to challenge you on the psychological reality of managing elite athletes, though. Because you know exactly what happens. You have a psychologically eager, highly competitive athlete sitting in your clinic at 8 weeks.
Oh yes, I know the conversation well.
They have zero pain, their active range of motion looks perfectly mechanically sound to them, and they are begging to play at the weekend because it's a cup final. How do you manage that patient when their subjective feeling completely betrays the reality that their biology simply isn't ready for a tackle?
That is arguably the most challenging and frequent conversation in sports medicine. It requires absolute clinical transparency and intensive patient education. I explain the microscopic biology to them, frankly.
What do you actually tell them?
I tell them, your shoulder feels great today because my high tensile hardware is doing 100% of the work. The screws in synthetic sutures are strong, but the biology, the living tissue trying to heal and vascularize around them,
Mhm.
is only 10% integrated into the bone.
That's a very blunt way to put it.
You have to be blunt.
Yeah.
I explain the physics. I say, if they take a full-force rugby tackle at 8 weeks, the synthetic suture tape won't break, the bone will. Exactly. The implant will act like a wire cheese cutter, tearing straight through the unprepared soft bone of the clavicle or coracoid. Managing these expectations begins preoperatively, setting the psychological roadmap clearly so they understand that feeling fixed mechanically in the clinic is vastly different from being healed biologically on a cellular level.
It is really about protecting them from their own ambition and physical resilience, isn't it?
Absolutely.
Well, this has been a truly phenomenal, granular exploration of a highly complex topic. As we wrapped up this deep dive, let us quickly synthesize the most critical pearls for the clinicians taking this back to their practice tomorrow.
I think that's a great idea.
First, never trust a static supine radiograph for an AC joint injury. Weight-bearing stress views are an absolute biomechanical necessity to unmask the true ligamentous pathology.
Oh,
Second, the robust data confirms that the vast majority of type 3 injuries function incredibly well with conservative management. The surgeon's true clinical acumen lies in identifying the high-demand, high-shear outlier who actually requires intervention. Third, if you are utilizing a hook plate for acute fixation, you are issuing a strict 3 to 4 month eviction notice to prevent catastrophic acromial osteosis. And finally, respect the biological clock. Delayed chronic reconstructions yield significantly poorer functional outcomes and higher complication rates than acute fixes, making early specialist referral absolutely critical.
a perfect summary.
Professor, before we sign off, what is a forward-looking thought on the horizon of AC joint management that listeners should be watching out for in the coming years?
Well, we have largely mastered the rigid mechanics of fixation, but the future undeniably lies in manipulating the biology. Keep a very close eye on the rapid development of dynamic synthetic ligament scaffolds augmented with potent biologics.
Biologics like stem cells.
Yes, specifically concentrated stem cells or advanced platelet-rich plasma formulations. The ultimate goal over the next decade is to develop a bioactive synthetic scaffold that provides the immediate, high-tensile mechanical strength of a tightrope, but actively induces rapid, robust, native tissue regeneration along its matrix.
Wow, essentially blurring the line between a simple acute repair and a complex chronic reconstruction.
Exactly. That biological bridging is the next great frontier in orthopedic sports trauma.
A fascinating, highly promising prospect to watch for in the literature. If you found today's deep dive valuable for your clinical practice, please take a moment to rate the show and share it with your colleagues and trainees. Professor, thank you for sharing your unparalleled clinical expertise and walking us through this highly complex biomechanical landscape.
It has been a fantastic, rigorous discussion. Thank you for the opportunity to explore it with you.
And to you, the listener, thank you for dedicating your time to advancing your clinical knowledge. Our goal is always to equip you with the highest level of evidence so you are ready for your next difficult clinic or theater list. Until next time, keep exploring, keep questioning, and keep diving deep.